Yeah, so this is the body chart where the patient is supposed to mark his pain. Body chart should be marked preferably by the patient, and the therapist is required to make him understand how he is supposed to mark it. So if there is pain, say on the hip region, he has to put a cross. So cross means yes, there is pain. That is how that is how the markings are done in a body chart. So it also enables the patient to mark whether the pain is radiating or not. You can ask the patient to put a long arrow down from the point of source till wherever the pain is referring or radiating to make us understand that the pain is radiating or referring. These are the standard ways of documenting any pain history using a body chart, which enables the other therapist, if you are handing over the case to somebody else, or if the patient is going to move to some other therapist, the therapist can see the documents and can understand where is the pain and what is the type of pain, whether it's radiating or not radiating. So body chart is meant to help all of us understand about the pain what patient is presenting with. Next we have relationship of symptoms. So most of the times you would have seen patients coming to you with back pain, which is simultaneously the patient complains of knee pain also. So there can be two instances. There can be a patient who is having back pain, which is getting radiated till the knee, or there can also be a patient who has back pain and knee pain separately. So here in this case, we need not just jump into conclusion thinking that back pain generally radiates, so which is why the patient has both the pain simultaneously. Here we need to ask the patient very clearly whether you think that when the back pain starts, simultaneously the knee pain also starts. When we are bending forward, the back pain starts, whether the knee pain also starts during the bending of the back. If that is the case, if that is when the pain starts simultaneously in both the areas, we can say that these two pain are related, which is known as relationship of symptoms, whether the pain are related to each other or not. But there can be cases where the patient says, no, I have back pain when I bend, but knee pain comes only when I'm climbing the stairs or coming down the stairs, which means patient has a different knee pain and he has a separate back pain, which are the two are not related. So it's important as a physiotherapist for us to understand that the symptoms are referring or radiating or not, which helps us in better diagnosis and thereby better planning of the treatment. Next we have clearing areas. So to understand what is clearing areas, I'll give you one example. Say if I have neck pain and which may or may not radiate to my arm. So to be very specific on the region, I will have to ask the patient whether do you have pain on the shoulder, whether you have pain at the back of the neck or below the neck, the scapular region, the hand, the elbow, because sometimes the cervical pain radiates. At the time when you are assessing the patient, it may not radiate, but it may radiate when the patient is doing some work. So we need to be very clear whether the pain is radiating or not radiating, whether he's free of symptoms in any other joints. So we need to ask whether all these other areas are symptomless, free of pain. And if it is free of pain, those areas are clearing areas. That means I have cleared those areas without any pain. And if the patient says, no, I also get pain in shoulder, it sometimes radiates, then that means those are the area of symptoms. The area is large now. It can be cervical, it is shoulder, it is elbow also. Clearing areas is basically those areas where there is no pain. Next is behavior of symptoms. So behavior means how the patient's pain behaves. Whatever he's doing, whatever he's performing, whether there is any change in the symptoms. Those are known as behavior of symptoms. So the first is aggravating factors, which means that what are those movements where the patient's pain increases, what aggravates the patient's pain. So in case of a back pain, generally patient says, whenever I bend down, I get a lot of pain. Whenever I'm lifting a heavy weight, I get pain. Those are the aggravating factors for a back pain conditions. If we talk about shoulder pain, Whenever I lift something from the top of the shelf, I get pain. Any overhead activities or sleeping on the same side, I get pain. Those are the aggravating factors. So you need to ask the patient which all the movements increases your pain. Next, relieving factors. What are the movements reduces your pain? So if it's a back pain case, again, patient may say, when I lie down in supine or in prone lying, my pain reduces. Or when I am just sitting, not standing, my pain reduces. Those are the relieving factors for that condition. So every condition will have a different aggravating and relieving factors. The pain behaves differently for every condition and every joint. Coming to irritability. So irritability means once the pain starts, how long it takes for the pain to come down. That means how much time does the pain takes or how much duration it takes for the pain to come down. For instance, if I have shoulder pain and I ask the patient, can you do this movement? Okay, so I get pain. The pain starts. Now I will ask the patient, now the pain has been started, but how long will it stay? Whether it's reduced as soon as you got the shoulder down or if it's still there. If the patient says that, no, once I stop the movement, the pain goes away absolutely, that is known as zero irritability, no irritability at all. That means in no time the pain reduced. That means once the movement stopped, the pain reduced. Next condition can be, so if I did this movement and now my pain has started, it will take 5 to 10 minutes to reduce the pain, which means the pain is mildly irritable. Similarly, when the patient says it takes at least 15 to 20 minutes or max 30 minutes for my pain to come down, once it starts, it is moderately irritable. And the third condition can be, once I do the movement, the pain stays more than half an hour or sometimes throughout the day. That is known as severely irritable. Now, why we need to know all this? Because when we are assessing the patient, we need to know prior when we are moving the shoulder or moving the joint of the patient, so that if the condition is too irritable, if the pain is too irritable, we may not be able to conduct a further examination. So if my abduction movement is irritable, I may prefer to either not to do the movement on the same day, or maybe if I really want to assess that movement, I will do at the last after assessing everything, so that the pain which I am going to provoke in a patient will not hinder my assessment, and I can later do some treatment to reduce the pain. The severity is how much is the pain, the quantity. Pain is a very subjective nature, has a very subjective nature. So you need to ask the patient how much on a scale of 10 you get pain. So there are scales like visual analog scale and numeric pain rating scale, where you can give the patient the scale and let them mark and ask them that where is the pain, how much is the pain. On a scale of 10, from 0 to 10, how much do you think your pain is? That is known as severity. 24 hours pattern is whether your pain is throughout the day or it is only on certain time, like maybe just morning pain, or maybe when I just do some work, only then I get pain. 24 hours pattern, whether you have morning pain, evening pain, night pain. So morning pain generally tells you about any active inflammatory condition, also a degenerative condition. Night pain will tell you about again an acute inflammatory condition, and it can be also because of any nerve case, sometimes a carcinoma also. Screening questions will involve certain important questions to rule out any red flags, also to rule out any important factors which can lead to symptoms which we are unable to treat. So for example, if I have back pain which is of discal nature, we need to ask the patient whether during coughing, sneezing, you get pain. So when the intra-abdominal pressure increases, it can put pressure on the disc also. So these are the screening questions in a discal case. Do you have any sudden loss of weight, loss of appetite? All these are screening questions if you are suspecting of any carcinoma or any tumor. Next, we have history of the current condition, which is the past, which means whether similar episode happened in the past, 2 years back, months back, and the pain stopped. But again, the patient came back with a similar condition. So the history of present illness was why the patient is here in front of you today. That is today's current condition. Whether this condition happened previously, any episodes were there in the previous months or years, that comes into history of past history of current condition. So medication history should be taken in brief, where we can understand whether patient is on any hypertensive medications or whether patient is on any painkillers, whether he is on any, he's a diabetic and he's taking medications for diabetes. These are important for us when we are prescribing exercise to the patient, which should be documented very well. Other than that, we also should know whether there was any surgical history relevant to the present condition. So if I have back pain today and if I had a history of a back surgery 5 years back, this is relevant for the condition, today's condition, so that all we should be documenting. The family history is important to understand whether there is a condition developed in the patient which is running in the family. Like diabetes, hypertension, RA, osteoarthritis. These are conditions are genetically related also. So we need to understand whether the family also has this condition so that we know what could be the intensity or how much intervention we are supposed to give in such a patient. Next is environment history, where we should understand that ultimately the patient is going back to the same environment where he developed a condition. So if I am a teacher and if I develop knee pain or back pain, so my environment is such where I have developed such a condition. So you need to train the patient or give exercise in such a way that patient can return back to his environment, so that the environment where the patient is going to work will not lead to again the same repercussion of the same condition. So either we fix the environment or we fix the patient in such a way that the environment where the patient is going to settle will not restart his symptoms. Social economic history is important to know, find out whether there are any caregivers, what is the educational level of the patient, and also who is the breadwinner. So we come to an idea that whether the patient can understand the treatment, whether the patient is able to afford the treatment, or how much you can explain the condition to the patient so that you attain a good cooperation. So personal histories like habits of smoking and alcohol should be noted down. What patient prefers to do in his leisure activities such as gardening, reading books, or what are his basically habits when he is free, maybe playing tennis, playing basketball, anything can come under leisure activities which he is not doing professionally. So this was about the subjective examination we learned today. So if you have any doubts, please contact me. Thank you.